Good morning. Mr. Faller and his team visited Vilnius 2 months ago. We had a very nice discussion, and he liked some of the ideas we presented. So, if invited me here, if it is very boring, so this is all his fault. Yeah. So, in Lithuania, we have only one big insurance fund, national insurance fund. I'm managing this organization. This is an agency of 425 professionals, and our budget for this year is 4.3 billion euros in total. So on the income side, National Health Insurance Fund in Lithuania, we have basically two sources of income. One is the tax on your salary if a person is employed, and we charge 7%, 6.98, because that sounds nicer, like in supermarket, 2.99 is always cheaper than 3 francs. So 7% of your salary to a fund, and those who do not work, so pensioners, children, prisoners, then the government pays to our fund based on minimal salary. And average salary in Lithuania is 30,000 euros per year. Minimal salary is 13,000 euros a year. So government pays 7% of that minimal salary. And there is a big discussion that the government should increase that contribution to the fund. But of course, due to geopolitical reasons, now the defense budget is taking all the attention. So most likely we'll have to wait a couple of years until that happens. There is a small group of self-employed people, farmers, and they pay 7% of their income. But this is only about 30,000, around 30,000 people. So it's 1% of the population. Not very important. And on top, municipalities make a small contribution, about 1-2% of the total fund, when they support acquisition of a small equipment, but their contribution is really very small. So basically, in our service prices, we take into account all depreciation of the buildings, acquisition or amortization of the assets, MRIs, salaries, laboratory tests, everything. So whatever we pay basically is 100% of the cost which the hospital or outpatient clinic incurs. Now, fund is growing from year to year. But basically, we are stuck at 7%, at 5% of GDP, and there will be needed some financing reforms in the nearest future if we want to improve that. We need more money for higher salaries for nurses to make that profession more attractive for younger people to come to this difficult industry. We need more oncology, new products. So most likely we'll have to raise taxes or find another way of financing. And compared to other European countries, with our 5% of GDP, we're closer to the bottom. So we believe that we should tax more, and when people are healthy and when they are sick, they should not pay too much. Now, as we are governmental organization and the only one, so we are somewhat cheap to run. We outsource tax collection to Social Security fund, the same which takes care of our pensions or unemployment benefits. So they collect taxes and transfer to us, and we pay to this fund 0.13% for the collection. Additionally, our agency, those 425 persons, servers, security, everything costs us about 1% of our annual budget. So it's about 40 million euros a year. About 20% of the fund, we are currently about 880 million euros we keep in a reserve. We invest in some government bonds or deposits in the banks, but we keep it for the rainy day. You never know, and this 20% was calculated based on financing troubles in 2008, and it took about 2 years until we got back to the normal income. So politicians always say, let's spend it now because they want to be re-elected. And we say, okay, let's keep some of the family silver in the family. Always difficult discussion. Now on expenses. So 77% of our payments to the hospitals, polyclinics, family doctors are spent on salaries. And we think that salaries for nurses and doctors are already more or less in line with the European average. It's about, this year, 2005 is not, we're still collecting data, but it will be about 2.4 times average income for the doctor and about still 1.1 for the nurse. And we would like, in the insurance fund, we would like to push income salaries for the nurses closer to 125% of the average, national average. So then we think the profession will be more attractive, and there will be more young persons choosing that as their career. Now, on the number of nurses and doctors, so Vice Minister interviews said that we will need more doctors. On the average, Lithuania has a little bit more, about 10% more doctors than European average. But again, plus 10%, this is a kind of error, margin of error. And yes, we lack some of the nurses, and would like to transfer more responsibility to the nurses and employ more of them. Now, how we pay. So that's the big difference from Switzerland is that we don't touch the patient. So we have almost no contact with the citizen who is visiting hospital, outpatient clinic. We do not send invoices to that person. We pay hospital or polyclinic based on the number of visits. The only time when we contact the patient if he has a complaint. So when we make analysis of the hospital and it looks suspicious, that could be overcharging us, could be strange procedures done, so when we will contact patient. Otherwise, we have 3,000 partners, family doctors, hospitals, outpatient clinics, nursing homes, and we pay them based on the services provided. So that's why we are so cheap. We don't touch 3 million citizens. So family doctors, 70% of the income, if I would be a family doctor, so 75% of my income would be a capitation based on the number of the persons in my clinic, and based on the age of that person. We plan to implement more multimorbidity index, maybe, or frailty index in the future, but currently it's only age dependent payments. Then we have a small add-on capitation if it's a rural resident or with some special needs. About 10% of income is on value-based payments. like children vaccination, flu vaccination for 65 plus, or cancer detection, and that works not very good. And we most likely in coming couple of years would like to change that. Looks like we are paying extra about 50 million euros a year, and there is no quality improvement whatsoever. So family doctors, we are just doing their job, and if that money comes, small amount additionally, so it's okay. If not, they don't care much. So, and one of the problems could be that the incentives are very far away from the efforts. Current system is that we make an average of their performance in 25, for example, and based on that performance, we will pay a small monthly fee additionally in 25. So it looks like it's difficult for them to connect me, and we'd like to switch more to maybe quarterly or even monthly evaluation, feedback on their performance, and payment accordingly. So when, like a student, before exam, but to make an effort and the remuneration closer together. And fee for service, 50 million more a year we pay for tests. Most of that is vaccination and some tests. For example, if a family doctor has a diabetic patient, we will pay 4 times a year. We will compensate for glycated hemoglobin tests, and our payment will cover the test and some 2-3 euros extra. So it's a small profit for a family doctor to do that test as well. Now, on other payments, basically most of them are fee for service, per visit, per case. In hospitals, we used modified Australian DRG, quite far away country. I don't know why we chose that. We have a Nordic, there is a Nordic DRG which is a bit closer, but that was done some 15 years ago, so it's now really difficult to change. We calculate ourselves prices for about 1,000 outpatient services and about 4,000 DRG services. We index based on salary development and inflation, all those prices usually in December. And we recalculate or deep dive and check if the structures of the service price changed, but we do that approximately only for some 15% of the prices every year. So that means that we will recalculate with a deep knowledge of the price once every 7 years, and we'd like to move that to do once every 3 years. But we go in and say, okay, how much does it cost to have a university consultation of cardiologist, like Professor Jurkevičius? So how many minutes of the professor we need, of the nurse, how much equipment they have to buy, what is the depreciation of this echoscope or another device, and calculate every euro and add up and say, okay, this is 105 or 155 euros per consultation if it is done within 25 minutes involving nurse and all this equipment. So we do it now once 7 years. We'd like to switch to once 5 years. And you can see that we have almost no value-based payments. Currently, we would like to go there. We plan to do, but we're still discussing how to do. Another problem, most interesting part, because if everything is very good, so no, nothing to talk about. On life expectancy, it's very clear trend that if you spend more money, you live longer. But this Lithuania is a little bit below the curve. So we moved a little bit up, but still we could do with current money, even with current money, we could do somewhat better. Maybe by 2-3 years for the life expectancy. So that means something is wrong in our society or in financing or in medical system. So we did quite significant jump during last 10 years of life expectancy and mortality, avoidable mortality, but still way to go. And if you look into preventable causes, which is a bit boring part when you say, okay, you have a healthy living, and so there is no much money involved. So it's a really boring topic, but that could save, if Lithuania moves to the level of Switzerland, we will save 4,000 lives every year. So currently we have about 37,000 people die every year. So out of 37, 4,000 could not die if they take care of themselves. And on treatable causes, which is hospitals, doctors, pharmaceuticals, that if we go from Lithuania to Switzerland level, we will save 3,000 lives a year. So it looks like our problem is efficiency, availability of the money, and quality. And for Switzerland, it's more efficiency question because quality is already there. So it's more difficult for you when it works. Why to change it? So I think it's very difficult for you to start moving. It's like a digitalization and Swedish Post. If a post works well, why we need an email? So yeah. So one of the problem is Lithuanian people do not care much about their own health. We smoke more, we drink, and we drink more vodka than wine or fortified beer. Then physical activity, of course, we do not are not so active as Dutch with their bloody bicycles. So only some 20% of Lithuanians exercise 150 minutes a week. I'm on the borderline, I think, with this activity. On flu vaccinations, even our 65 plus, they think we are immortal, and only 20% get a flu vaccination. And we have about 100 dead people at the end of the year, at the end of the flu season every year. And they could be alive. Maybe not all the 100, maybe 90 of those or so could be alive if they got a flu shot. Now, with a fee-for-service payment system, we have, which is very usual everywhere, quantity beats quality. So you get what you pay for. So, and another big problem in our country, and I think this is a very nice example from your system, that currently we lack patient co-payment for the services. The only place where patient pays a little bit is a pharmacy, but also we pay about, on average, about 3 to 4 euros per prescription. So it's, and last year patients or their relatives returned about 40 tons of pharmaceuticals, sometimes for destruction, and of course a lot of those were just thrown to the waste. But sometimes they bring pharmaceuticals for values of 20,000 euros unused. So, and when a person doesn't pay much, so there is no incentive to save. So I believe that patient co-payments on hospital stays, nursing homes, specialist visit, maybe not family doctor, because family doctor still should be a little bit more closer to the patient. Most likely that will come, but with current social democrat government, it's very unlikely. And medical standards. So German, UK NHS, they have quite nice standards how each disease has to be treated, and medical society accepts that okay, this is the best way to treat something. And we have for most threatening diseases, we have very good standards for oncology, where it's really complicated which product, which pharmaceutical, when radiation, and when surgery is working better. But for more common things, we still lack of those standards. And we have a lot of referrals because family doctor doesn't pay for referral. So it's easy for him to send a patient, see a cardiologist, see a pulmonologist. And family doctor is not suffering financially. And I know that financial solutions is not everything. We cannot reduce all the medical complex system just to financing. But financial incentives, they work a little bit. And that's why we have a lot of doctor visits. Average Lithuanian goes 10 times to the doctor every year. And average Swedish person 3 times. So there must be some space for improvement for us. And avoidable hospitalization when rather a healthy person ends up in the hospital is more common in small regional hospitals. They are trying to attract patients. We say, okay, stay a couple of days in the hospital. They charge us some 2,000 euros, and that helps small hospitals to survive. And it could be that if we press more, that those conditions should be treated somewhere in the outpatient department, that hospital will go bankrupt. And there could be a pressure that we pay some general budget fee for the hospital just to keep it around in certain area. And could be that the spending will be the same. So currently we are pressing a little bit to go down with avoidable hospitalizations, but do not overdo that. On solutions part, we still believe that family doctors could do more, and we plan to have incentives for those family doctors who write less referrals to the specialists and take care better of the patients. Let's see how that works. Then our emergency departments are overcrowded, and about 40% of people who come to a hospital emergency department, they don't need emergency department. But this is a very nice place to get consultation, X-ray. It's very fast. You have no, from a normal pulmonologist, you will wait 2 months or 3 months. When you go to emergency room, you get service within some 6 hours. So that's quite common. Singapore, UK, we say the same. The more you improve emergency department, the more patients you get. And this is kind of like a curse for this. Yep. So day surgery, we're quite good. Within last 5 years, we switched most of the operations which can be done in day surgery from the hospitals, because hospitals, this is a dangerous place to be. Hospital infection, it costs more. So cataract surgery, cholecystectomy, phlebectomies, most of that is done. More than 80-90% is done now in day surgery. Excessive consultations, this is a problem, and we try to do something about that. And there are very complex questions when patient insists, I want a second opinion. And then in oncology, that could be important, because this is really very stressful situation for a person. And he gets a cancer diagnosis. And we get about 16,000 cancer diagnoses every year. So that could be justifiable. But for the cardiologist to say, okay, please take your statin medication and you will avoid stroke or heart attack, I doubt if we need a second and third opinion for the patients. And at least insurance fund should not pay for that. But of course, there is a problem with the competence of a family doctor. Sometimes he's lazy and says, "Okay, I will make you a referral." So that's why we will try to implement more financial pressure for family doctor or incentive to not to send away persons. And on data transparency, we mentioned a couple of times. We are lucky as a small country, less than 3 million people. We have a central electronic health record system. Every polyclinic or hospital, they have their own, but there is an exchange of the data, and I have my own app, and I can see my visits from different doctors or book the appointment in my smartphone. We're still working on exchange of radiology imaging, and would like to have a network of servers which exchange, and neurologists could see my head scan from a year ago in another hospital. So that this access is made easy. Laboratory standardization is coming. And as an insurance fund, we intend maybe next year, maybe 28, we'll start paying extra 1, 2, or 3% of the contract, so that for Kaunas Clinic will be 3 to 6 million euros extra for the maturity of the digitalization. That means that if only the standard, minimum standard is met, we will pay, let's say, 1% extra. If we get reports of the cost of a patient per patient basis, if there are data is well structured, not just a PDF with a lot of text, and we have to put artificial intelligence to search through those bloody PDFs. But if the data is really well structured, that everything is in their place, we plan to pay up to 3% extra for this type of a hospital, so we will have money to spend on IT systems. Yep. And so this is Vilnius, and there is somewhere this our office is somewhere there. Thank you.